Thank you. Morning. Well, in the last class, we have been talking about actually the late post-operative complications of cataract surgery. We have seen that actually late post-operative complications are, one is assisted macular edema and retinal detachment, fibrous ingrowth, epithelial ingrowth, fibrous downgrowth, and all these things, and also finally a posterior capsular opacification. So this posterior capsular opacification can be because of actually the retained lens matter in between the anterior capsule and posterior capsule admixed with fibrin because of the chronic uveitis, or it can be because it can be lens matter admixed with blood in case of hyphema. These are the two things. And the second one is actually because of the proliferation of and epithelial cells from the anterior capsule. It sweeps around actually the posterior capsule, giving rise to a posterior capsular opacification. So there are four types of actually posterior capsular opacifications. One is a tenure posterior capsular opacification, and second one is a thick posterior capsular plaque, and Sommering rings and Elshnig spires. Okay, these Sommering ring actually it is a retained cortical matter in between the anterior and posterior capsule, and it is usual in the periphery. So the Elshnig spires, so they are actually vacuolated epithelial cells which are on the posterior capsule. So because of actually the anterior epithelial cells sweeping around the capsule, it happens. And the management actually of these cases, suppose if the patient is having a defective vision and if is not able to manage with the existing vision, in such conditions actually we try to intervene and do it. So suppose if it's a thick, it's a tenure PCO which is not interfering with the vision, and if the patient is normal, the vision is 6.6 or 6.9 and near vision is N6, normally we don't touch the patient. Suppose if the patient is having reasonably a drop of vision, in such conditions actually we try to interfere and do something. So a Sommering ring, actually it's in the periphery. Suppose if the center is clear, we don't touch it. Elshnig spires and thick posterior capsular opacity in the center, such things actually we do interfere and we try to do something. So what we do is normally is actually the posterior capsular opacification is very rare normally if it is properly done cataract surgery before 6 months of the surgery, before 6 months post-operative period, and we normally try to tackle actually the posterior capsular opacity 6 months after the surgery only. Okay, so what we do is actually it is most common in pediatric and developmental cataracts, and less common in the elderly age group. Less common in the elderly age group. What we do is actually we deal the posterior capsular opacity either with the Nd:YAG laser or surgically. So Nd:YAG laser, what we do is we instill a drop of local anesthetic and ask the patient actually just before the laser. And what we do is actually we pass the laser 1 millijoules approximately onto the posterior capsule. We fix the target. The contraindications for YAG capsulotomy are a corneal scar or corneal opacity, which cannot actually allow us to focus the target onto the posterior capsule. So normally we do it in a cruciate fashion. We start at 12 o'clock and go to the 6 o'clock and 3 o'clock to 9 o'clock. And that gives a cruciate opening in the posterior capsule, which has been opacified after surgery. Okay. So next what we do is, suppose if the opacity posterior capsule is thick and we are not able to cut it with actually YAG laser, or in the event of actually non-availability of YAG laser, in such conditions what we do is we rather do it surgically. What we take actually a cystotome, pass it from somewhere, and we just cut the posterior capsule. And another one we have is a Ziegler's knife. And the Ziegler's knife, with Ziegler's knife also we are going to cut the posterior capsule. And after the posterior capsular this thing, the patient will have a good vision and he will not have any problem. Okay. So in the examination, we will ask you regarding actually the types of IOLs also. So the types of IOLs, so initially, as I told you, actually from 1880 to 1990, we were doing an intracapsular cataract extraction, and the whole lens is removed in toto. Say anterior capsule, nucleus, and also posterior capsule, completely we remove it. There is no posterior capsule actually to put in a posterior chamber IOL. Okay. In such conditions, we used to rather correct or rehabilitate the patient in the postoperative period with phakic glasses or contact lenses. The problems with the phakic glasses I have already mentioned. Have already mentioned to you people. One is actually, suppose if it is a uniocular aphakia, so the patient other side actually the vision if it is 6/6, so the patient will have a diplopia. The reason is actually there will be a magnification of nearly 30% of the image with the phakic glasses. Okay, so the other side, the image being normal, so we'll have the problems actually with for these two images. They will not coincide at the cortical level, and the patient will have actually a diplopia. And second thing is the spherical and chromatic aberrations associated with that. If narrowing of the field of vision, a roving ring scotoma, pincushion effect. Another thing is actually pincushion error, Jock-in-box phenomenon. All these things have said they do occur. Finally, it's a cosmetic blemish. That's the reason actually the people, they will not prefer to have an ICC done and wear phakic glasses. Suppose if it's a bilateral aphakia, they may actually definitely accept in a better way than the uniocular aphakia. Okay, so that's the reason. After we thought by when we have seen actually the problems associated with aphakic glasses, we thought other alternative, that is actually contact lenses. Contact lenses, there will be magnification of around 7% of the image. So there won't be any problem of diplopia, the chromatic and spherical aberrations, they are not there with it, and the field of vision is full and everything is normal. But the problem associated with contact lenses is actually the cataract is mostly in case of elderly patients. So in elderly patients, there will be senile tremors and there will be difficulty actually in introducing the contact lenses. And secondly, there will be relative dry eyes in the age group of around after 60 years. So dryness of the eyes, actually it is a relative contraindication for implantation, rather wearing the contact lenses. So finally, we got into the option of actually the intraocular lens implantation. The first person who has implanted actually intraocular lens is first and for this Harold Ridley, a British ophthalmologist. He has implanted the intraocular lens into the left eye of a 45-year-old female in St. Thomas Hospital, London on 25th November 1949. But the problem associated he had with his lens is actually the lens is very heavy, about 20 grams. So naturally, it could not stay in on the posterior capsule and it went to the bottom. So later on, there are a lot of experiments which have been actually very interesting and often frustrating, and finally with good results. And now we have well-developed lenses. Okay, so the various types of lenses we have are based on method of fixation. So suppose the one is anterior chamber lens. So suppose if there is no posterior capsule, be it an extracapsular cataract extraction with a large posterior capsular end, or an intracapsular cataract extraction. In such cases, actually, we put in an ACI valve. So ACI valve, it has got its own complications. What we would Kelman multiplex ACI valve, actually, it is a well known lens, and it's actually it has got less complications than with other rigid lenses. Okay, how we do it actually, after extraction of the nucleus, we try to constrict the pupil with intracameral pilocarpine or acetylcholine, 1% acetylcholine, and then we put in the lower haptic at 6 o'clock position, and upper haptic actually we leave it at 12 o'clock position. Okay, so the other anterior chamber lenses are iris clip lenses, iris claw lenses, iris lens with suture or with claw, or we put it actually Singverse iris claw lenses. So these are also associated with lot of complications, chronic uveitis, and all these things. They are very common with iris suture, iris lenses with sutures or loops or claws or whatever it is. Singverse iris claw lens actually it is class lo ఉన్న తర్వాత వచ్చేస్తాం. Iris, so Singverse iris claw lenses are the second one actually. And next we have started having posterior chamber lenses. So in the posterior chamber lenses, they are of modified C loop or quadri loop, and these are well tolerated for nearly about say lot of time, a few decades. And the posterior chamber lenses, either they can be kept in the bag, that is, you do a continuous curvilinear capsular excess, and you after inflating actually the bag, after removal of the nucleus and also the perfect cortical cleanup, we inflate actually the bag with either sodium hyaluronate or polymethyl methacrylate. And then we put in IOL, the lower haptic, first of all, we put it into 6 o'clock position, and later on we try to dial the upper haptic into the bag. So in the bag, IOL is the best mode of actually intraocular implantation. And secondly, suppose if you don't have if you could not do actually a capsular excess, maybe some problem, maybe a small rhexis or maybe a large rhexis or an escaping rhexis or whatever it is, what all these complications can occur while doing actually rhexis. So in such cases, actually, the lens can be put in sulcus, ciliary sulcus. So if you have sufficient posterior capsular attachment, okay. Third one is a scleral fixation. So suppose if you don't have posterior capsule, already if the patient is opaque previously, in such cases, actually, we can put in a scleral fixation lenses, either with sutures. We put this scleral fixation, or we rather glue the lens with glues. Without sutures, actually, the haptics actually can be glued with the cyanoacrylate glue. Okay, so these are the things actually we can put. And retro iris fixation, iris claw lenses can also be tried in the posterior chamber. So these are the various, depending upon actually the material. So there are various materials such as polymethyl methacrylate, silicone, hydrogel, polymer. All these things actually we can prepare actually the IOLs. So polymethyl methacrylate actually is a substance with which we make actually rigid lenses, the routine non-foldable posterior capsular lens, which we keep actually in the bag or in the posterior chamber in the sulcus. Okay, and foldable lenses, they are actually prepared by silicone, acrylate, and hydrogel and polymer lenses. And rollable lenses, in which we actually put in what you call a small, very small, less than a millimeter incision, so phaconate. Okay, in such cases, actually, this is micro incisional cataract surgery. So the hydrogel actually is the substance with which we make actually rollable lenses. Okay. So based on focusing capability, so the lenses are different. One is unifocal. Most of the cases actually we do unifocal this thing. The patient is well corrected for distant vision in the immediate post-operative period. After 4 to 6 weeks actually, we try to correct for near vision also. So once actually the lens, natural lens is removed, the accommodation is knocked off. So the patient's near vision will be compromised, and we'll have to rehabilitate him actually to have a good near vision also. And if at all there is any problem for say astigmatism, or suppose if the IOL power is not well corrected, if there is actually a hypermetropia or myopia, that also will be corrected in the immediate post-operative period in unifocal lenses. So multifocal lenses, otherwise known as simultaneous vision lenses. So these can be two types. One is a refractive multifocal lens and a diffractive multifocal lens. And here actually the patient can have a distant, intermediate and near vision with the same thing. The other one is an accommodative IOL. Here, anterior movement of optic improves actually the near vision in accommodative IOLs. So there are different models. Crystallens, synchronilens are also there, and extended depth focus lenses are also there. Technis, Symphony lens. They provide actually uncorrected distance, intermediate, and also near vision. Okay, and aphakic versus phakic lenses. So aphakic lenses, you know pretty well that these things actually they are done immediately after the surgery when we remove the cataract and put in an IOL. There are different types of IOLs actually we have mentioned, and we just put in a IOL. Okay. So in case of phakic IOLs, in case of actually very high refractive error, so high myopia, -20, -18 or so. In such conditions, actually, we put in an IOL, implantable collimator lens, actually. This corrects actually the high refractive error of the individuals. So what we do is normally we do routinely, we make an incision in the superior fornix after the fornix-based conjunctival flap and cauterization and all these things, and then we do an iridectomy, and then we pass in the phakic IOL over the already existing lens. Okay, so that actually neutralizes the power. Suppose if the patient is having -18, we calculate what power actually should be inserted, what power of phakic IOL should be inserted, and we put in that IOL, and the patient will have normal vision in the immediate post-operative period. So there are other special types of lenses. One is a toric lens. So the toric lens, toric IOL is actually the patients with astigmatism. So if you want to reduce actually the amount of astigmatism in the post-operative period, if the patient's pulse is good enough, in such cases they can go in for actually toric lenses. It costs around $1.5 lakh or $1,20,000 or so for toric lenses. Okay, and aspheric lenses are also there. They reduce actually the chromatic aberrations, spherical aberrations of the lenses. And aniridia lens, aniridia means actual loss of iris. Iris will not be lost completely. The small piece of iris will definitely be there. So in such cases, actually, we put in aniridia lens to reduce the photophobia in the post-operative period. So here actually the optic will be in the center, and there will be a diaphragm, brown diaphragm around the optic, so that the patient will have a good vision in the post-operative period, and he will not have any problem with the light and everything. Photophobia will not be there. So you will have to, before actually inserting any of these IOLs, actually you will have to calculate the power of IOL. Okay, so the power of IOL, the power of IOLs are actually you can calculate by certain formulas. SRK2 formula is one where P is equal to A minus 2.5 minus 0.9 L, 2.5 L minus 0.9 K. Okay. So A is at P is equal to power of the lens, A is surgical constant, L is actually axial length of the eyeball, and K is corneal curvature, anterior and posterior. Corneal curvature horizontal and vertical. So average of this actually will take, and we have a scan and also the keratometers, so which give all these readings. And once actually you feed all these things, you get actually intraocular pressure. Before going on to the displacements of the lenses, I forgot to mention the other complications of cataract surgery. So that is complications associated with lens. One minute, I think it went out somewhere. కొంచెం మళ్ళీ ఇది వచ్చింది మా మాట పాతదానికి అడవ వీడియో కాదు ఇంకోటి చూస్తాను ఇక్కడ ఏమైనా ఉందా ఏం లేదు ఇది కాదు ఇంకో పేపర్ లాస్ట్ క్లాస్ లో చెప్పింది అది కాదు ఇంకోటి
ఈ టైటిల్స్
పాత ఇంకోటి ఉంది కదా మూర్తి అని ఉంటుంది చూపించు ఉందో లేదు ఒక దాంట్లో అది పెట్టు అది మీకు సిడి కంటెంట్స్ మూర్తి అనుకోండి ఏంటో ఇది ఇందులో ఉందో అందులో ఉందో అన్ని మర్చిపోతుంటాను నేను ఇవి చాలానే ఉన్నాయి So I told you actually, I forgot to mention about IOL related complications. Whenever intraocular lens is implanted, so there is a possibility that there can be cystoid macular edema, about which actually we have talked already. And a corneal endothelial damage can occur. Suppose if the surgery is not good, if there is a lot of actually corneal endothelial loss during surgery, in such cases actually there can be a striate keratopathy grading from say grade 1 to grade 4, leading on to actually corneal decompensation. So that can give rise to this. That's nothing but actually corneal endothelial damage, grade 4 corneal endothelial loss, or straight keratopathy, which may necessitate actually a keratoplasty. And we can have actually an uveitis, chronic uveitis, or an acute uveitis immediately in the post-operative period also. There can be uveitis because of extra handling of the iris and also the surrounding areas. So the patient may have an aqueous flare in the immediate post-operative period, varying from grade 0 to grade 3 or so, grade 4. So in such that also we treat with steroids, and normally it comes down. And a secondary glaucoma can also occur in cases of IOL incision, after IOL incision. And UTH syndrome, this is most uveitis, glaucoma, and hyphema syndrome. This is most commonly seen in cases of anterior chamber IOL. Okay. So a rigid IOL lens, which is actually anterior chamber lens, which is placed in the anterior chamber, it can give rise to UGS syndrome. And nowadays it is very, very rare actually. We are rarely putting actually an SA IOL. Mostly the posterior chamber IOL, suppose if the PC is not normal, in such cases actually we are putting in a scleral fixation IOL, and that is definitely far better than the anterior chamber IOL, which can give rise to all these complications. So the malpositions of IOLs are another thing actually which we'll have to talk about. One is decentration, and second one is subluxation, and third one is dislocation can occur. So we have very fancy names for decentration of the IOLs. One is sunset syndrome, so the IOL goes down, and sunrise syndrome, the IOL goes up. In these two conditions, what we do is actually we try to reposition the IOL. Suppose if the IOL is occupying more than 50% of the pupil, in such conditions we can try to constrict the pupil by installing myotics, and the patient can be refracted and he may have actually good vision. Suppose if it is not possible in such conditions, what we do is we try to reposition the IOL. Suppose if we have sufficiently large enough, more than 50% to 60% of posterior capsule is intact. In such conditions, you can try to put back your IOL into the particular place, and if there is any joinular adhesions and vitreous in the particular area, you can as well do an open sky vitrectomy or with a vitrector, and that normally, and then constrict the pupil, and that solves the problem in case of sunset and sunrise syndrome. Suppose if it is not possible in such conditions, what we do is we explant the IOL, and then we put in a posterior chamber IOL lateral. Suppose if there is already vitreous and if it is sinking into the vitreous, so in such conditions, better not fish out actually the IOLs, because better refer the case to a vitreoretinal surgeon, and vitreoretinal surgeon, they will take care of, they will do a pars plana vitrectomy. They will do a pars plana vitrectomy and put in a posterior chamber IOL. Okay. So another thing is a lost lens syndrome. So what will happen is here actually the lens can be lost into the posterior vitreous. So completely it's dislocated into the posterior vitreous. In such conditions, what we do is we don't try to fish out the IOL. We just refer the case to the vitreoretinal surgeon who will do either it can stay in the vitreous and move, and or it can get fixated onto the retina, and either lens nutans or lens fixator, that's what we call. And it is a posterior chamber surgeon or a vitreoretinal surgeon who will do a pars plana vitrectomy and try to remove the IOL and then put in a PC IOL, scleral fixation IOL. So the next one is a windshield wiper syndrome. Here, a small IOL is put with the haptic left in the 12 o'clock position and another left in the 6 o'clock position. If it is not dilated to 3 to 9 o'clock position, what will happen is the IOL will move like just like wipers of a car wipers. They'll move like car wipers, just like car wipers. Whenever the patient moves his head from one side to another side. And another, finally we have toxic lens syndrome. So this toxic lens syndrome actually is another thing which is seen with because of the ethylene glass, which actually is used to sterilize the IOL. So that can give rise to toxic lens syndrome. And toxic anti-segment syndrome is another thing actually which can occur. It is also because of ethylene glass, which is used actually for sterilizing the IOL, and that can give rise to severe symptoms in the immediate post-operative period, such as an acute uveitis will occur, and one will have to differentiate this from an endophthalmitis. Okay. So another complication is glaucoma in aphakia. So this also can occur in the patients after cataract surgery. It can be because of raised IOP in the early postoperative period. So the raised IOP in early postoperative period, it occurs, suppose if we leave some amount of viscoelastic material in the anterior chamber or in the lens and behind the posterior capsule in the gap there, if we leave it, so this will go and clog the trabecular meshwork and it will give rise to raised intraocular pressure. So in the patient is having a raised intraocular pressure in the immediate postoperative period, the eye will be, cornea will be a little edematous. And when you take actually intraocular pressure with appellation, Goldman appellation tonometer, so it is rise. In such conditions, actually what we do is we try to give either a local timolol maleate 0.5% twice daily, or if necessary, actually a nizolamide tablet also 250 milligrams thrice daily can be given. Secondary angle closure glaucoma due to flat AC. So the flat AC can occur either because of a wound leak or because of ciliochoroidal detachment, or it can occur because of actually a malignant glaucoma. So the secondary angle closure or pupillary block is also another cause actually which can give rise to secondary angle closure. So what will happen is when there is a wound leak and when there is a flat AC, the peripheral there will be formation of peripheral anti-synecia, and that can give rise to angle closure glaucoma in case of flat AC. So secondary angle closure glaucoma due to pupillary block. So this occurs, this used to occur previously when we used to do intracapsular cataract extraction because of the vitreous bulge and vitreous blocking the pupillary region that gives rise to an iris bombay and also peripheral anti-synecia and secondary angle closure. Undiagnosed pre-existing primary open angle glaucoma is another condition which can rather manifest or which can be diagnosed first time in the immediate post-operative period. So you treat, we come to that in the, I think next week we are going to talk about primary open angle glaucoma, and then we discuss about the management of it. And other thing is a steroid-induced glaucomas. There are actually the steroid-induced glaucoma, it occurs in people who are steroid responders, high responders. It's about 5% of the population who are high responders. About say 90% of the, about 65% of the population, they're non-responders, 35% moderate responders, 5% only high responders. In high responders only, suppose if we instill steroid drops or give systematically the steroids, so that can give rise to a raised intraocular pressure. So the management is cessation of the steroid, and second one is actually you give local anti-glaucoma medication, and that solves the problem. And the other causes can be an epithelial ingrowth. We talked in detail about epithelial ingrowth, and if at all there is a raised intraocular pressure because of the epithelial ingrowth, we have seen the management also with the laser, and also we can do a trabeculectomy or a glaucoma valves and all these things. Aphakic malignant glaucoma can also occur. So that will be managed in the lines of malignant glaucoma. We will come to that next week. మళ్ళీ బాధ్యాన్ని గడువ ఇవన్నీ ఒక్కొక్క చోట ఉండడంతో మీద ఇబ్బంది అవుతుంది. Base teaching topics by the way. LENS-VIII number base. ఇది వచ్చేదా so hitherto we have seen actually the late post-operative complications of cataract surgery and also various types of intraocular lenses, and now we'll go on to actually the congenital anomalies, displacement of the lenses. Most likely I'm going to talk about it. So let me fish out so ectopia lentis or dislocation or subluxation of the lens. A congenital dislocation or subluxation lens can also occur. Either it can be hereditary. So congenital dislocation and subluxation is mostly hereditary. Okay, simple ectopia lentis. So displacement is usually bilateral and symmetrical upwards. Autosomal dominant inheritance is there in these conditions. Okay, and ectopia lentis at pupillae is another condition where actually it is inherited by autosomal recessive manner, and displacement of the lens associated with slit-shaped pupil, and they go in opposite directions. The displacement to if it is nasal, and the slit-shaped pupil will be up to the temporal side. And other associations associated with ectopia lentis at pupillae is there can be cataract and there can be glaucoma, and the people, they may have actually an axial myopia, and macrocornea can also occur. Abnormal iris illumination pattern will be there, and retinal detachment is also seen in these cases. So when you examine actually these people with slit lamp by microscope, the lens is actually a smaller one, and the edge of the lens is visible on pupillary dilatation. And second one is we have a Marfan syndrome. So here the lens is displaced superior-temporally, and it is a autosomal dominant inheritance and connective tissue disorder affecting skeletal and cardiovascular systems. The patient will have erectinodactyly, that means the long spattery fingers will be there in these patients, and long extremities will be there, and the length of outstretched arms will be equivalent to the length of the individual. And hyperextensibility of the joints is another feature of Marfan syndrome, and congenital inguinal hernias can also be there. And high arched palate is another thing which we normally see in these cases. And dissecting aortic aneurysm is a cardiovascular anomaly, and ventricular septal defect or patent ductus arteriosus are also seen in these cases. So this is actually Marfan syndrome, where you have a superior-temporal displacement of the lens. And the other one we have is homocystinuria. Here the displacement is infero-temporal, and the inheritance is autosomal recessive. So it's an inborn error of metabolism, lens subluxated inferonasally, as I have already mentioned. And fair complexion of the individuals will be there. There will be malar flesh. Mental retardation of the children, it occurs. The patient may have convulsions and poor motor control. And diagnosis is by detecting homocysteine in the urine by nitroprusside test. Okay. And Weil-Marchesani syndrome is another syndrome actually which occurs with displacement of the lens. Here actually the lens is spirophakic here. The lens is spherical in shape, and anterior subluxation with the pupillary block, glaucoma, can also occur in these cases. And the individuals with the Weil-Marchesani syndrome will be of short stature, stubby fingers will be there, and there will be mental retardation. And the other one is Ehlers-Danlos syndrome. So here actually the patient will have subluxation of the lens, and there will be blue sclera, and there will be hyperextensibility of the joints, and loose skin with folds. So all these things they do occur actually in Ehlers-Danlos syndrome. And another one is we have hyperlysinemia. It is actually inherited in an autosomal recessive manner. It's an inborn error of metabolism due to deficiency of alpha ketoglutarate reductase. And here actually the patients will have lax ligaments, hypotonic muscles, and patient may get actually convulsions, and mental handicap is associated in most of the cases, and subluxation of the lens is seen in these children. Stickless syndrome is another condition where actually you have this ectopia lentis. So sulfur oxidase deficiency is another condition where you have the subluxation, rather displacement of the lens. This disorder is inherited by autosomal recessive manner. This is a disorder of sulfur metabolism, and you see actually ectopia lentis and progressive muscular rigidity, decerebrate posture, mental handicap. It's a fatal disease, and normally the children they pass away below 5 years. Okay, so clinico-etiological types of actually displacement of the lenses is one is a traumatic displacement. We have talked about actually couching. So this is the initial mode of management of cataract, where actually the patient used to make sit, and the surgeon used to sit in front of the patient, and after local anesthesia, so they used to take a heat needle, pass it at the limbus into the pupillary region, and push the lens behind into the vitreous. So as I told you, actually the patient will see the surgeon's face immediately, because this used to be done in case of premature and mature cataracts where the vision is only perception of light. But I also told you that actually the pleasure of having good vision is short-lived, and this used to result in most of the cases as phacotoxic endophthalmitis or panophthalmitis, and they used to lose the eye. So the couching is there's an example of traumatic displacement of the eye, and spontaneous displacement due to mechanical stretching and degeneration of the nodules can also occur in case of high myopia, in case of ophthalmos, and all these things. Secondary to eye diseases, in uveitis. So in uveitis, actually, there can be a subluxation of the lens. In hypermature cataract, where actually you see the jonular descents or weakness of the jonules, and this can give rise to actually a subluxation of the lens. And pseudo-exfoliation syndrome is another thing where actually the pupil will not dilate, and there will be an association of glaucoma, so primary open-angle glaucoma in these cases, and there will be jonular dehiscence. So that can give rise to a subluxation or subluxation of the lens, and ciliary body tumors in the posterior segment. So they can give rise to actually displacement of the lens. So this, I think we have talked about it already. Subluxation is partial displacement of the lens, and the lens remains behind the pupil. It is due to partial rupture or unequal stretching of the jonules. So the patient will have actually a defective vision, marked astigmatism, mostly lenticular myopia caused by the edge of the lens. And uniocular diplopia can also occur, and AC is almost always deep, and there will be iridodonesis and phycodonesis. So when you examine actually these patients, the edge can be seen as a dark crescent on the distant direct ophthalmoscopy, and a shining golden crescent when you examine the patient with the slit lamp biomicroscope. So fundus, when you examine the fundus, suppose if you see the fundus through the aphakic area, so the disc will be small, and it's a hypermetropic fundus. Suppose if you see through the phakic area, so the fundus may be normal. So the complications of subluxation are either complete dislocation of the lens can occur, And cataractus changes can occur in already a clear subluxated lens, or uveitis can occur, and secondary glaucoma can occur. So management of a subluxated lens is either with the spectacle correction or surgery. Surgery is when you do surgery, there is high risk of actually retinal detachment. Spectacle correction normally when we do it through in the phakic area, suppose if the lens occupies more than 50% of this thing, and we try to construct the pupil, and then we do actually spectacle correction. Suppose if it is the phakic area is less, in such conditions, actually you can as well correct a phakic portion. Even the spectacle correction, if at all, suppose it is not satisfactory to the patient, in such conditions, actually what we do is we do a lensectomy with anterior vitrectomy and posterior chamber IOL implantation, scleral fixation mostly. So dislocation of the lens, all the granules here are severed, and dislocated lens may be incarcerated into the pupillary region, or it can go into the AC, or it can drop down into the vitreous, or it can go onto the retinal subscleral space, or extruded out of the globe also. So clinical features of posterior dislocation are there will be deep anterior chamber, aphakia will be there, iridodonosis will be present, lens in vitreous. When you examine the patient actually with the ophthalmoscope, in an indirect ophthalmoscope, clinical features of anterior dislocation are the lens actually in the anterior chamber, it looks like, suppose if it's a clear lens, it looks like actually an eye drop. And complications are, there can be uveitis, glaucoma, and there is every chance of actually the patient going for a corneal decompensation. So management, lens in AC, whether it is cataractus or whether it is a clear lens, whatever it is, in immediate removal is mandatory. Lens in vitreous, it is removed if uveitis or glaucoma they occur. A pars plana total vitrectomy, lens removal, then we place in actually an IOL. So this is ectopia lentis pupillary displacement associated with slit-shaped pupil. Etiopathogenesis is breakage or weakening of the journals. Degree of displacement depends on sectoral involvement. Clinical features I have already mentioned. There can be poor vision, uniocular diplopia, and glare, astigmatism, myopia, and accommodation will be definitely altered because of the partial severing of the jonular dehiscence. Signs will be displacement of the lens. Either it is, if it is an anterior displacement, it can be actually in the pupil will be dilated, iridodonosis, phacodonosis, deep AC, and herniation of vitreous into the anterior chamber can also occur. Anteriorly displaced lens, I have already told you that if it is associated with glaucoma, we try to reduce actually intraocular pressure initially, and then we try to remove the lens. And a subluxated lens, I have mentioned refraction, aphakic portion, correction. Usually it is well tolerated, but the other eye is actually 6x, the patient will have the problem. A posteriorly dislocated lens with uveitis, removal of the lens is mandatory. No uveitis, you can as well wait and see. And usually nowadays we are not leaving actually the lens, we remove it and replace it by, say, posterior chamber IOL, that is scleral fixation IOL, because the patient will have to have good vision. Excessive lenticular astigmatism, the patient is having excessive lenticular astigmatism because of actually the subluxation or subluxation of the lens. Then also we remove the lens. Lens aspiration and lensectomy, these are the two things actually done. And this is again a subluxated lens, and this is a phakic area, and this is phakic area. Erechinodactyly in Marfan syndrome, slender, long fingers. And this is microspherophakic lens dislocated into the anterior chamber. And subluxation of the lens with correctopia. So here actually the pupil is not in the center. So the subluxation of the lens is also there. And here actually I think there is a subcoloboma of the iris also. And posterior lenticonus, anterior persistent hyperplastic pupil primary vitreous is also there. Here actually this is this area, the anterior persistent hyperplastic primary vitreous. This is persistent posterior lenticonus here, and anterior dislocation of the lens in both the eyes here, you can see. This we have already seen. I think tomorrow we are going to talk about the congenital and developmental cataracts, and also the congenital anomalies of the lens. So before that, actually, I forgot to mention, there will be, so suppose if you do the surgery, if you put in the IOL after extracting the nucleus immediately, then it is called actually primary IOL implantation. Secondary IOL implantation is another procedure where we don't put in the IOL immediately on the first sitting, and we try to put it in the at a later stage. That is secondary IOL implantation. These two things actually you must know. So they are these things actually we have seen. So any doubts? Sound is not audible, sir. It's beyond me. I cannot help all these things. Okay. We'll try to tell the technician and he's going to improve it. Okay. Sorry. No pain. Yes, sir. Sound is not audible, sir. Better.